أنا محمد أنور. أول شكرا لكم الحضور كلكم، ويعني نرسل تحياتنا وكثير الشكر للدكتورة ساشا على إنها على وقتها وعلى المحاضرة اللي حتقدمها القيمة إن شاء الله. وإن شاء الله ده برنامج حيستمر كده لفترة. محاضرة ساشا طبعا حتكون هي عبارة عن بارتات، كل فترة حتكون عندها محاضرة، غير طبعا الأقسام الثانية والناس الثانيين. المحاضرات اللي حتكون من دكتور فيصل وراني وباقي الشباب. حاليا في المحاضرة دي إنه إن شاء الله دكتورة ساشا حتشرح المحاضرة كاملة، وبعد ذاك الناس اللي عندها أسئلة وحابة تسأل إن شاء الله بعد المحاضرة حيكون في وقت لأنها تسأل كل الأسئلة ويحصل الدسكشن إن شاء الله. أتمنى إنه الصوت بس يكون واضح واصل للناس.
واضح يا محمد، تمام.
أوكي دكتورة ساشا تفضلي، معك المايك.
تمام. السلام عليكم ورحمة الله تعالى وبركاته. Very good evening. So I'm so pleased to share with you these updates about cardiovascular prevention. This is part 1, as Dr. Muhammad mentioned, and we'll have more parts later talking about all what related to cardiovascular prevention, cardiovascular disease prevention. Hopefully, inshallah, this presentation will be like light and enjoyable to all of you, inshallah. So start talking about cardiovascular prevention. Just a minute, making sure that the presentation will. Okay, fine, that is good. Now, talking about cardiovascular disease, as we all know, this disease or this group of diseases remains like one of the main cause of morbidity and mortality worldwide. And when we say cardiovascular disease, we'll be talking about all the disorders related to cardiovascular system, including or starting from hypertension to arrhythmia, including coronary artery disease or coronary artery syndrome, like angina, myocardial infarction, heart failure. All those diseases will be included under this umbrella, cardiovascular disease. And as we know again that those diseases are preventable. So they are preventable means it's very wise to deal with or to prevent those diseases before taking place. That will be wiser and will reduce the overall morbidity and mortality worldwide. Now, cardiovascular disease will lead to 18 million people across the globe to die annually. 18 million. That is very huge number. Now they keep talking about coronavirus, mortality rate, blah, blah, blah. The whole story about coronavirus did kill like 500,000 or around this figure. So cardiovascular disease is really a serious disease or a series of group diseases. And as far as they are preventable, as we said, it's more wise to deal with prevention more than treating this disease later, because the disease once will take place, that means complications. We are talking about the pumping organ. That means will affect the oxygen supplying all the organs, and that means ischemia all over, and that means complications. Some of them are irreversible complications. So it's better to deal with prevention from the beginning. For today, we'll be talking about the lipid guidelines updates, as lipid is one of the main components of the risk factors leading to cardiovascular disease. Cardiovascular disease is good and bad to say that though the rate or the prevalence of this disease is or declined in developed countries, and bad to say that it's very dramatically increasing in developing countries. And that is maybe due to health awareness in developed countries, maybe due to governmental programs, very systematically taking place there in developed countries, and we are so far from that, of course, in our countries. Now, previous guidelines have validated low density lipoprotein. This is, we all know that LDL cholesterol is the bad cholesterol, isn't it? So LDL cholesterol, the previously or previous guidelines validated this LDL cholesterol hypothesis. And they call it hypothesis because nowadays they are keep updating this issue. Yes, it affects the cardiovascular disease. Yes, it might be participating in this or experiencing this disease. Yes, the increase in LDL cholesterol will definitely affect or lead, one of the leading factors to cardiovascular disease. But whether or not LDL cholesterol is the only component among the lipid profile to be blamed in cardiovascular disease, that is what we need to discuss. Because we have some guidelines confirming that it's not only about LDL, it's about other components. Okay, and based on that, again, previous guidelines and still continuing or are still continuing, and even the recent guidelines are talking about the effect of statins as universal treatment and of course prevention for cardiovascular disease. And then recently they added ezetimibe. Ezetimibe is a well-known cholesterol or lipid lowering agent. So again, we'll talk about this during or throughout our presentation. New data has been published on those new family of lipid lowering agents, which are the proprotein convertase subtilisin kexin-9 inhibitors. Isn't it long and ugly name? It is. Those agents, in short, we can say PCSK9 subtilisin kexin-9 inhibitors is a newly developed, published family of lipid-lowering agents. Those agents are effective in lowering cholesterol, and that is good, but they have a very big limitation. They are very expensive. This is really important to mention. They are not cost effective. And by saying that, by telling that those medications, as pharmacists, you know, practicing pharmacy, even though this medication is very effective therapeutically, but if this medication is still expensive, that means simply the patient will not be able to afford. So what is the use of this therapeutic effectiveness, isn't it? There is no point of. So those medications are still effective, as we said, therapeutically, but because of their cost, which is really high, they will be considered only in specific situations, will be mentioned later. But kindly, I want you just to memorize this shortcut at least. Just memorize this PCSK9 inhibitor, because we'll be mentioning them later and we'll need to recall at least this shortcut. PCSK9 inhibitors. Recent guidelines have investigated the best lipid fractions to predict cardiovascular disease, suggesting two main issues. Additional cardiovascular risk factors, because we cannot rely only on LDL cholesterol as a risk factor, of course, and potential role for biomarkers. Biomarkers, those are the elements to test and to monitor, using them to monitor the cardiovascular risk. That, of course, will allow more improvement in cardiovascular risk calculation. Good and nice. Now, before going further, we need to make sure that, or to remind ourselves, some meaning of some terminologies here. Like, for example, hypercholesterolemia and dyslipidemia. Are they the same? Because most of the times they will be considering them as the same thing. Hypercholesterolemia and dyslipidemia. They are definitely not the same. Because simply hypercholesterolemia means elevated cholesterol, plasma cholesterol level with normal TGs, with normal triglycerides. So hypercholesterolemia means hypercholesterol level only in the plasma, not including the TGs. Okay, fine. What about dyslipidemia? Dyslipidemia is a broader term, is a combined or mixed term, is irregular lipid profile, generally lipid profile, including the TGs. And if you can just notice what I said now, dyslipidemia means irregular lipid profile. I did not say that whether it's high or lower than normal, because both are included under dyslipidemia. Both are included in dyslipidemia. Dyslipidemia, like dysrhythmia, for example, when you say dysrhythmia means irregular heartbeats, that might be tachyarrhythmia or bradydysrhythmia. Increase or decrease. Again, dyslipidemia will give you the same meaning, whether it's increased or decreased in the whole lipid profile, including TGs. Dyslipidemia and hyperlipidemia, now it's clear. Dyslipidemia means either higher or lower than normal, and hyperlipidemia means mainly higher than normal lipid profile, including the triglycerides. So we need to consider here the familial hypercholesterolemia. And here, if you can notice, among LDL cholesterol more than or equal 190 milligram per deciliter. Now, let us remind ourselves the levels, LDL levels. Of course, all of us know about the LDL levels, but just to remind ourselves that the optimal level for LDL cholesterol is supposed to be less than 100 milligram per deciliter. The borderline level is 130 to 159. The high level is 160 to 189. So 190 is considered high. So among adults with high LDL cholesterol, 1.7% of them are familial hypercholesterolemia patients. And significant to tell that among acute coronary syndrome patients with borderline high LDL cholesterol, 8.7% are familial hypercholesterolemia. That familial means genetic, isn't it? Means inherited. Now, familial hypercholesterolemia, they'll keep telling that they are autosomal and monogenic. And what does that mean? We all know that autosomal means, when you say autosomal dominant inheritance, for example, this is from our basic genetics. That means one copy of an altered or defective gene in each cell is sufficient to cause the disorder. And that is exactly the situation in familial hypercholesterolemia. And monogenic means a specific gene in a specific chromosome will be blamed of causing this situation. And this gene is the PCSK9 gene. Does that remind you something? Remember this PCSK9 inhibitors, the newly developed medications which are very effective but expensive? Now we'll mention why and how those medications act and how they act in lowering the cholesterol level, especially in familial hypercholesterolemia, because this is the gene which is defective that will lead to abnormality in the situation, FH. And this gene is found specifically in chromosome 19. So what this gene will do? Before that, let's just raise this point about or talking about the LDL particles, LDL cholesterol particles, which will be freely travel from extracellular to intracellular, from extracellular, the blood, to intracellular based on the level in the blood. If LDL cholesterol particles increase extracellularly, means in the blood, that will activate the receptors, LDL receptors, which are found in all over the cell membranes, in all over the body. Will activate those receptors to bind the LDL cholesterol particles from outside and capture them, ingest them inside the cell. And through this, the concentration of LDL will be lowered. So this is the situation. That is the normal situation. If there is a defect in this gene, PCSK9 gene, which is a pro-protein convertase subtyrosine casein 9 gene, this gene will activate the attraction between this enzyme PCSK9 and LDL receptors. That means this enzyme will bind the receptors instead of the LDL cholesterol particles. And based on that, LDL cholesterol will not find empty unavailable receptors to bind and to activate their ingestions inside the cell. That means LDL cholesterol will shoot up extracellularly, means in the blood. That is exactly what will happen because of this defect or mutation in this specific gene. And that is why we need to block this PCSK9 enzyme and not allowing this enzyme particles to bind the receptors, LDL receptors, instead of LDL. And at that time, LDL particles will find available LDL receptors to bind, and then the particles will be ingested inside the cell, and the LDL concentration will decrease. So this is the mechanism how the PCSK9 inhibitors act. But as we said, the problem here is in the cost. They are not cost effective. They are very expensive. They are not affordable by the patients. Now, those are the 6 points to follow here in my presentation, summarizing all the guidelines updates, the European guidelines, the US guidelines, and even the NICE guidelines, the national study. We'll talk about it, and even sometimes the UK guidelines. So the 6 points to raise and the 6 points considered in the last 5 years, including first, a greater emphasis on early detection and diagnosis of the disease. The importance and significance of the early detection, because the earlier the detection, the better the prevention, and the less or the lower the complications. Second, new biomarkers, either new biomarkers or even updated information on older biomarkers. What about advances in technology and availability of imaging? Because imaging will allow more clearer picture to prevent the disease better. What about the expiries of patent protection for most statins and now ezetimibe as one of the options? Very nice medication to be added to statins sometimes, as we'll talk about it. And what about the PCSK9 inhibitors? And then the last point is novel trial data in secondary prevention populations. Now let's start with greater emphasis on early detection and diagnosis of disease. As we said, the earlier the detection, the better the prevention. Now, lipid guidelines use the LDL as a single parameter. That is what previous guidelines used to do. To take a single parameter LDL as a single LDL cholesterol as a single parameter to predict the the cardiovascular risk. And for primary prevention means what? Means the patient is not yet diagnosed as having cardiovascular disease, but he or she is under risk, but he's not yet a cardiovascular disease patient. Okay, now for primary prevention, the target LDL cholesterol is just like marginal to the high. Till 190 will be considered okay. Although 190 is considered high, but for primary prevention, because the patient is not yet cardiovascular disease, will not go that much to optimum. I mean optimum level. For patients with secondary prevention, means already got and diagnosed with cardiovascular disease and survived the first attack. Now for this patient, or patient under high risk to develop cardiovascular disease. So how to know that this patient is under high risk to develop cardiovascular disease? That will be based on some study score calculator. And the eldest study score calculator has been done by Framingham. And Framingham study is the eldest calculator to calculate the risk, cardiovascular disease risk, considering multifactorials, more than one factor, risk factor, not only the LDL. So Framingham is considering the diabetes, considering hypertension, considering gender, male or female, considering age. Okay, so how Framingham study score calculate the cardiovascular risk? Okay, cardiovascular disease risk, I mean. Let's imagine that you have a patient who's 70 years old. Now, this 70 years old is falling in a range of age categories that will be given certain points. Let us say from 60 to 70 will be given like 3 points. Let us say male or female. Again, male will be given some points, female will be given certain points. Of course, as we all know, male got higher risk to develop coronary artery disease and cardiovascular disease in general. Fine. Then diabetes. Then Framingham study or score is considering diabetes as yes or no. And this is one of the limitations of this study. Yes or no, not considering controlling of diabetes, the length of the disease itself, whatever. No. Whether this patient is diabetic or not, okay, that will be reflected as some points. Hypertension, that will take the mean systolic blood pressure. Fine. What about a smoker or not? Yes or no, they will be given some point, and so on. So then after a while, after doing all that, translating all the risk factors into points and translating again, converting those points into percentages, then based on that, they will categorize the patients into 3 categories: mild risk, moderate risk, and high risk. If the patient got 10%, that means the patient is a mild risk patient. If it's 10 to 20, that means the patient is a moderate risk. If it's 20% and higher, that means the patient is high risk patient. And what do you mean by 20% risk? That means this patient X is expected to develop the first attack within the coming 10 years by 20%. And that is considered very high. And based on that, they will decide to start the primary prevention regime, which is including the 4 items. We all know about the items of the primary prevention regime, which includes 2 individual variation components and 2 fixed components. Because the 2 components which are very individualized is to control the blood glycemia and to control the blood pressure. Controlling blood glycemia and blood pressure is very individualized. Each patient will have his or her own regime to follow. Perfect. Then Controlling the blood pressure, again, is very individualized. And the two fixed components are aspirin, low-dose aspirin, and statin. So based on the risk, the patient will be considered to receive this regime. And it's very important point here to add, because there is a myth here. The myth is telling that only in late adulthood, the lipids will start to accumulate in the arteries. And this is very wrong. As we all know, it starts accumulating since 2 years old, based on the family history, based on the lifestyle. Since 2 years old, the lipids will start accumulating in the arteries, and that will lead to plaque formation or clot formation at the end. But the thing is that the symptoms of the coronary artery disease will not show up unless the blockage of the coronary artery or any of its branches will exceed 75%. At that time, ischemia already took place in all over the body, main organs and everything. So the treatment will be will not be that much effective. That is why we keep talking about prevention. The studies considering multifactorial cardiovascular disease, as I mentioned, the first to consider the multifactorial cardiovascular disease risk is the Framingham study score, and all the recent studies are based on the Framingham study score. So they modified the Framingham study score. Like, for example, the European Systematic Coronary Risk Evaluation, this is very famous score calculator. And again, the multi-core atherosclerotic cardiovascular disease, ASCVD calculator, and all of them are advanced out of the Framingham study. Now, we need to consider that UK, which is very recent, the very recent UK calculator is considering more risk factors, like the UK General Practitioner Database allowed the development specific score adding more cardiovascular risk factors like ethnicity, because the studies being done in US mentioning that it's very different. The risk is very different based on their ethnicity, different ethnic groups in US. They mentioned that most ethnic groups with higher mortality rate in America are the African Americans, followed by the American Indians, followed by Alaska Natives, followed by Hispanics, for example. So that means ethnicity will be playing a very great role in cardiovascular disease risk. What about deprivation? And by saying deprivation, they mean socioeconomic deprivation. That will include account income, so the financial status, employment, education, crime history, etc., etc., etc. All those will be affecting the cardiovascular disease risk. What about mental health disease and autoimmune disease? And kindly allow me like seconds to show the relation between mental health disease, autoimmune disease, and cardiovascular diseases, because it's really interesting. Mental health disease or mental health disorder, we all know that mental problems are related to irregular neurotransmitters, isn't it? Irregular or imbalanced neurotransmitters like norepinephrine, like serotonin, like dopamine, based on the abnormality, mental abnormality. What is it exactly? Is it anxiety? Is it depression? Is it, what is it? Okay, so it's very well established, the relationship between cardiovascular risk and mental health disease is very well established. They mentioned that more than one reliable study is mentioning that this imbalance in the main neurotransmitters leading to mental health disease will lead to irregular calcium accumulation and buildup inside the arteries. And we know about calcium. Calcium is one of the main excitatory ions affecting the action potential in our body. So the buildup of calcium will lead to direct abnormal artery diameter. That will lead to narrowing in the arteries, arteriosclerosis. That is one direct effect. Then again, we know that calcium as an excitatory ion will lead to vasoconstriction and will lead to ischemia. So it's very, very well established till American Heart Association is considering depression, for example, as one of the major cardiovascular risks, like diabetes, like dyslipidemia, like hypertension, is one of the major risk factors. So 80% of patients with depression are under high risk to develop cardiovascular disease. This is very significant. Again, very main and court study is talking about the relation between depression and uncommonly sticky platelets. We all know that platelets, in the surface of the platelets, we have like the gluey material that will be released, allowing the platelets to stick together and the platelet aggregation to take place. That is the second step in clot formation to stop bleeding if there is an injury or injured area in the body. Now this is exactly, if you remember, is where aspirin will act as antiplatelet, because aspirin will stop this gluey material from being released, and that will minimize the stickiness of the platelets together. Good. Now returning back to depression, depression will lead to uncommonly sticky platelets, leading to unnecessary clot formation, and that will definitely lead to cardiovascular disease. So it's really important to consider the mental health disease as one of the main risk factors leading to cardiovascular disease. One more point to be raised here to make sure and to confirm more and more this relationship between mental health disease and autoimmune disease. This is what they call broken heart syndrome. Broken heart syndrome. Broken heart syndrome is a condition in which intense emotional stress will lead to rapid and severe heart muscle weakness. Can you imagine that? It's a very strong relationship. And that will definitely lead to stress, cardiomyopathy at the end of the way, and maybe heart failure. That is really important to raise. And that will confirm more this very significant relationship. What about autoimmune disease? What is the relation between autoimmune disease and cardiovascular diseases? We all know that autoimmune disease means hyperactive immune system, means releasing and production and release and sending more and more immune cells, like psoriasis, like lupus, like rheumatoid arthritis. All those are considered autoimmune disease. So this situation, any of those situations will increase the cardiovascular risk by double the cardiovascular risk by two mechanisms mainly. First, increasing immune cells will cause the cholesterol to become trapped outside or extracellularly and will not allow it to be captured inside the cell. That will allow buildup of LDL outside the cell in the blood, and that is hypercholesterolemia. Again, the immune cells, if in excess, will lead to directly will attack the myocardial muscle as antigen. We know that this is what autoimmune disease, what happened in autoimmune disease, that the immune system will attack the normal tissues in the body and destroy them. Now those cells will attack directly the myocardial muscle, will lead to inflammation, and then that will lead to inflammation either partially or the whole heart, based on the severity of the autoimmune disease itself, and that might lead to rheumatic heart disease. So again, this is very significant. The relationship between autoimmune disease and cardiovascular disease is really significant. Then US guidelines are introducing risk factors like chronic kidney disease, and this is well established. All of us know the relation between kidney disease and cardiovascular disease. It's multifactorial, it's bidirectional. Means, like for example, if the patient is having chronic kidney disease, that will lead to hypertension, definitely, because deteriorating kidney function will affect the control of the main system that for homeostasis, the renin-angiotensin-aldosterone system, leading to retention of fluids, and that will worsen the situation in the heart, especially in heart failure. Good. And then again, it's bidirectional, means that the cardiovascular system, if there is a defect in cardiovascular system, that will allow defect or will lead to defect in the kidneys themselves. Because if there is, for example, let us say cardiac failure, heart failure, that means the blood supply to all over the body will be diminished, will be less than needed by the other organs. So let us take the kidneys now. Kidneys will not receive enough amount of blood. That means the kidneys will start to stimulate the system, as we mentioned, renin-angiotensin-aldosterone, retaining more fluids, and the heart is filled already to pump the blood which is existing in the body. Now the kidneys will worsen the situation by retaining more fluids. So definitely they are very related to each other, especially now it's mentioned here as stage 3, which is an advanced stage. Okay, and that this relationship, they call this relationship as cardiorenal syndrome or cardiovascular renal disease. It's really important to know, and it's really important relationship that might lead to or worsen the situation. Fine. What about the biomarkers? Now, blood tests are inconvenient. They will keep asking about CBC, blood test. It's inconvenient. It's over ordered. It's not giving a significant effect or significant indication. Aslan. It's not this. It's disliked by the patient, and it will wasting money, because it will not reflect, as we said, the situation, the risk for cardiovascular disease. So why to go for it? Meta-analysis of cardiovascular disease, and this is really important point, is showing non-HDL cholesterol as superior for cardiovascular risk prediction to LDL cholesterol. Because the previous guidelines are mentioning the LDL cholesterol to monitor the risk. But now the meta-analysis, which is really big study, is raising the superiority of the non-HDL cholesterol. And what do I mean by the non-HDL cholesterol? Simply, to get the non-HDL cholesterol, you will be subtracting the HDL cholesterol out of the total cholesterol. Simply. So total cholesterol minus HDL cholesterol. HDL is the good cholesterol. So then by minusing this, you will get the whole picture of the bad cholesterol, because all the rest are bad cholesterol, considering LDL, TGs, very, very low density lipoprotein and others. All the bad cholesterol. And all the bad cholesterol, suppose the optimum supposed to be less than 130 milligram per deciliter. So the non-HDL cholesterol is better in predicting the risk for cardiovascular disease. Why? Because we need to consider the TGs. We need to consider the triglycerides. Triglycerides are troublemakers, really. They are causing, they are hardening the arteries, causing arteriosclerosis. They cause acute inflammation of the pancreas, leading to pancreatitis and hyperglycemia. Again, it's very related to HDL level. High TGs means directly low HDL. So we need to consider the TGs in the calculating the cardiovascular risk. And it's very simple, because you will get the components to get the non-HDL are already there. You have the total cholesterol, you have the HDL cholesterol in the lipid profile already. So nice. This is the National Institute for Health and Care Excellence Program are recommending that non-HDL cholesterol is very easy and very simple to calculate, because the components of this calculation are there already in this profile or in the lipid profile. Some other studies which are not that much big and reliable studies are mentioning the importance of monitoring the lipoprotein, the C-reactive protein, and troponin, but specifically they will not go for those monitoring unless the patient survived like myocardial infarction. Then later you will go for that. So they will not consider them in primary prevention, for example. No. So because all the time we need to weigh between the benefit and the risk, even the benefit like to be cost effectiveness. This is one of the benefits, of course. Imaging, if you remember, we said that yes, risk calculation is very nice. We'll be identifying like 70% of individuals who later have events. That is good. But what about the other 30%? So imaging will cover for those 30% patients. And that is good. And the imaging in the recent guidelines, which is very recommended, is the CAC, which is coronary artery calcium. Remember the calcium? Calcium as the excitatory ion and causing buildup and arteriosclerosis and all those. That is why they will go for CAC, coronary artery calcium, especially the European and US guidelines. All those guidelines updates are very recent, 2019, 2020. So both European and US guidelines incorporate coronary artery calcium score being done by cardiovascular CT, computer tomography. And this imaging will be covering the 30% of intermediate risk individuals, not only high risk. So that will be measuring the risk very early, and that of course will be added as positively impacting the effect of prevention. Now, CAC or coronary artery calcium, if it's 0, that means no calcium is seen in the heart. If it's 100 to 300, that means moderate plaque deposits in the heart. In the heart means I'm talking about the coronary artery or the branches of the coronary artery as main arteries in the heart. If it's greater than 300, that is a sign of high risk of heart attack. So coronary artery calcium is very recommended now in the recent guidelines reflecting the risk for the cardiovascular risk. About therapeutics, statins and ezetimibe, all guidelines now recommend the maximum tolerated dose of statin if you are talking about secondary prevention. So they will go for 80 milligram atorvastatin or equivalent like simvastatin or others. In primary prevention, they will not go for the high doses. They will go for 20 atorvastatin or equivalent. And very recently in 2020, US and European guidelines, they recommended type 2 diabetes as secondary prevention. So once the patient is diagnosed as type 2 diabetes or diabetic, that means will be considered as secondary prevention. That means the plaque is already there in the coronary artery, but it doesn't show yet. Because as we said, the plaque or the symptoms will not show unless 75% of the coronary artery is blocked. So type 2 diabetes is considered very recently as secondary prevention. Ezetimibe inhibits the intestinal and biliary cholesterol absorption. We all know that dietary intake provides about 1/4 of cholesterol entering the intestinal lumen, and this is mainly ezetimibe, where ezetimibe works, and 3/4 like derived from the liver. That is why, because ezetimibe is working only or mainly in the intestinal part, which is only 1/4, it's not that much effective compared to statins. So this ezetimibe, that is why they will be considering it as adjunctive therapy. Adjunctive therapy means supportive therapy, means not the main medication to lower the lipids. So they will add it to the statins, of course, plus the lifestyle modifications. Okay, so the combinations are available. We have the ezetimibe with simvastatin, with atorvastatin, with even rosuvastatin, I guess. The onset of ezetimibe is 4 to 12 hours, and the dose orally is 10 milligrams to be combined with the statins. So statin and ezetimibe will be considered, this combination will be considered in patient confirmed as acute coronary syndrome in one of 3 situations. Either if the patient is not reaching the target, even though we gave the highest dose of the statin, or if the patient is having familial hypercholesterolemia, or the patient is having statin intolerance, or the patient is statin intolerant. That is agreed by all the guidelines. And what do we mean by statin intolerant? They define the statin intolerant as having tried 3 different statins, reaching to the maximum doses, but it still didn't achieve the targeted levels. At that time, you need to add ezetimibe and combine it with a statin to achieve the target level. Remember the PCSK9 inhibitors like alirocumab, like evolocumab? Those agents are very nice agents. Therapeutically, they reduce the statins or the LDL levels by 60%. In patients taking statin, that is great. But as we said, the limitation is the cost. Like for example, the average cost for Repatha is evolocumab. This one, monthly, the patient has to purchase this medication by $450 monthly, which is most of the patients will not be able to purchase. To afford, they are not affording that. Some facts related to PCSK9 inhibitors. All guidelines agree on using ezetimibe as prior to those agents. So we'll be adding ezetimibe to statin prior to considering those agents. PCSK9 inhibitors are expensive. So even though will be considered, they will not consider it for life as a statin, for example, unless for 1 to 2 years only in highly resistant patients although the combination of statin and ezetimibe is being given. Monitoring lipids. In 2016, the US guidelines and NICE guidelines removed the LDL cholesterol from being important to be monitored as far as the patient adhere to their medications. Then at 2019, they reintroduced the LDL targets once again, and the target for those patients supposed to reach the optimum, especially if the patient is a cardiovascular disease already patient. So they will go for less than 100, and they will go for more than that, like till 55 milligram per deciliter in ultra high risk situations. We need, of course, to monitor the LFT, liver function test, the liver enzymes, because we all know that the cholesterol lowering agent, especially statin, will be mainly metabolized in the liver, will be affecting the liver function. And of course, we need to monitor the CK or creatine kinase. And we all know that creatine kinase is very related to the myopathy, very famous side effect of statin. Creatine kinase is the enzyme found in many areas in our body, like in the brain, like in the skeletal muscle, like in the heart. So increased CK will lead to or will indicate muscle damage due to whatever reason, like because of chronic disease, because of some injury, because of statin, for example, isn't it? So yes, patients are recommended to monitor CK or creatine kinase annually. First, they will start by monitoring every 6 months, then they will shift to monitoring CK annually. Future directions: treating all patients with established cardiovascular using high dose of statin and ezetimibe will lead to achieving this 55 milligram per deciliter LDL in 50% of patients. So that is good. And again, this combination is very cost effective. It's not expensive that much compared to the recent group. Then they don't need any monitoring. They are cost effective. They are therapeutically effective. As we said, will achieve the target in half of the patients using this combination. About PCSK9 therapy will be required for a small number of patients, as we said, in critical situations. Now at that time, the risk and benefit, the benefit at that time post-MI is outweighing the risk. So they will consider giving PCSK9 inhibitors. Okay, and again, the guidelines for PCSK9 inhibitors will not change in UK. That is what they claim. unless their price will change, because, as we said. So at the moment, guidelines recommend that at least 3 different statins should be tested before the PCSK9. That is what we mentioned about statin intolerance. Other new oral LDL lowering drugs like pempidoic acid, Nexletol, and this agent is effective and cost effective and very nice medication in primary prevention and or statin intolerance is to be considered. Again, we know about the second option with statin or after statin, which are the fibrates in treating elevated TGs. Especially, they will combine the fibrates with statin in type 2 diabetes. In complex dyslipidemia, it was found very effective and very beneficial in reducing the TGs. This link is for you if you are interested in knowing the mechanism. It's very interesting video, by the way, like explaining the mechanism of pempidoic acid. It follows like a complex mechanism of action, including many enzyme pathways, okay, for those who are interested in knowing that. Those are my references, and thank you so much for listening. Any question? Any point to discuss? Hello.
السلام عليكم ورحمة الله وبركاته دكتورة ساشا. في البداية حابة أشكرك يعني for comprehensive presentation about cardiovascular disorder covering this lipidemia. It was very interesting topic for all of us. I have one comment regarding depression and risk of cardiovascular disorder.
Okay.
That depression may also precipitate cardiovascular disorders, and also the presence of depression may precipitate cardiovascular disorder. Patient with the cardiovascular disorder may have depression also.
Yes, perfect.
Yeah.
Bidirectional, perfect. That is a good point.
Yes.
Right. Very nice.
That's my comment to your presentation.
Thank you so much. Very interesting point. Thank you so much, Doctor.
Most welcome.
Thank you, Dr. Sasha, for the very, very interesting presentation, especially for the people that aren't where their job isn't much in pharma anymore, like me, for example. It's a good refreshment because we're a little far away from. I'm still in the medical field. I work in a research company, but there isn't. It's good to refresh on updates on guidelines, updates on medications. So thank you very much. I would just like to let you know about my experience in regards to the CVD risk calculations and the equations that you were speaking about, that you touched on, the Framingham score and all the other available scores available right now. One of our studies that we're working on right now in our company, so we're working in collaboration with a pharma company, but it's a national study that they want to do, trying to come up with a cardiovascular disease risk calculator that is applicable for the Saudi population. So as you mentioned, that cardiovascular disease is a major complication of type 2 diabetes, and it's the most common reason of death. And these calculators that are available right now, they don't cover this, they don't cover type 2 diabetes, or they don't cover diabetes specifically. So, and usually what happens when you use these international calculators and try to implement them or adapt them in other countries, like the Saudi population, for example, they tend to either overestimate or underestimate the risk.
Right, correct.
So this is what they're trying to work on right now, is they're trying to conduct a national study. The sample size is going to be 5,000 patients with either type 2 diabetes or pre-diabetes. And they want to collect the same variables on these patients to come up with a risk equation that can be applicable to the Saudi population, that they can use in primary healthcare, in the primary healthcare centers, for primary prevention of cardiovascular disease, and specifically in type 2 diabetes patients.
You mean to be followed by the main settings here in Saudi Arabia, is it?
Yes.
To be followed.
Yes.
Because the challenge, Doctora, is that the problem is that the study scores are there, but it's very rare to be followed and to be practiced by the practitioner. This is really one of the challenges.
Exactly.
Even though, yes.
And
yes.
the other problem is that there's no standard calculator that's being used by all practitioners. So one physician في الحرس الوطني might be using, for example, the Framingham score. Another practitioner in another private hospital might be using the UK or the ASCVD. So this study is hoping, and the outcome بتاع إنه يكون في standardization for the method that's going to be used, and something that can be more applicable to the Saudi population.
That is really great, Wallah. That is
we're still in the beginning. We're still working on IRB approvals right now. We have 5 sites that we're going to be conducting the study in. منهم الحرس الوطني في الرياض، في جدة وفي الإحساء. And then we have المستشفيات العسكرية في الطائف وفي الشمال والجنوب. Because we're trying to cover all of the regions of the country, because there might be differences in different regions.
Yes, right.
برضو معانا واحدة من المستشفيات الجامعية هنا الملك خالد. So it's going to be a retrospective study. So we're going to be collecting data retrospectively 5 years before starting 2013. And we're going to see, follow up these patients and see when they had a cardiovascular event and what was the cardiovascular event, and has it occurred more than once. We're going to collect data on MI, on heart attack, on stroke, all of these cardiovascular events. And then hopefully this will be helpful for the for nationally for Sterdia. So I'll let you know. Hopefully when we get some results, I'll let you know how it goes.
Wallahi, that is really interesting for me, because my study has been done in 2005, 2006 in Malaysia. It was all focusing on that. It was like primary prevention, coming up with some guidelines there, and then to find out whether the physicians are adhering to that or not. Because we found that the patients like develop cardiovascular disease retrospectively again, most of them did not receive the primary prevention, because they were high risk, but they did not calculate the risk for them, and they did not consider them as high risk patients. So based on that, they did not give them or prescribe them the primary prevention regime. Yes. That is very sad to say. So it's great, wallahi, great efforts. Yeah, yes. MashaAllah, that is really impressive.
Thank you. Nice. Thank you so much, Dr. Sasha.
Thank you for sharing with us, my dear. Thank you so much.
دكتور فيصل تفضل.
السلام عليكم.
وعليكم السلام ورحمة الله.
Thank you for such interesting presentation. Just I would like to hear from, as most of our audience are from community side, just we would like to hear about the role of pharmacists in management of the lipid.
Great point.
If someone can share, yeah, because that's the most important thing as community pharmacists. What is our role in helping our patient to control their lipid?
Perfect.
I mean, like if there's any program, like lipid management program that implemented among community pharmacists to educate patient about like controlling or managing their lipid?
Well, Dr. Faisal, if you allow me, I don't know about the policies there here in Saudi Arabia, but I don't think there is a program to be followed like educating the patient, unless it's very individualized in the settings, in the hospitals, very individualized by the practitioners themselves. So unless you will find your patient, especially not the community pharmacists, especially the hospital pharmacists, because they will be following with the patients, and they will be exposed to the patient's records and patient's files and so on. So they will know that this patient is like following, taking and refilling the same medications. So means that approximately this patient is under high risk to develop this disease, and then they might like initiate that, like educating the patient about the lifestyle change, physical activities, and eating healthy food and others. But I don't think, and correct me if I'm wrong, hospital pharmacist, if there is a program to be followed, systematic program to be followed for patient education under high risk. Because as Dr. Sahar now mentioned, that they are not following, they are not even calculating the risk for the patient. Once they will calculate, they will know that this patient is under high risk, and then they will, based on that, they will follow specific guideline to educate, blah, blah. That is reason, that is exactly what we mentioned, Dr. Faisal, in the first few slides. We said that the cardiovascular disease is declining in developed countries, isn't it? While increasing dramatically in developing countries. And I guess here is still considered as developing country, because we don't have health awareness, we don't have governmental programs, we don't have. So this is what I know. If I'm wrong, any of you can correct me on that.
Yeah, I think what you I agree with what you said, but like my point was because not everyone have access to the hospitals. Most of the community will receive their medication from community pharmacy. So I think if we have an awareness program through the community pharmacy, because I believe that changing the lifestyle will make difference for prevention of like complication because of high lipidemia.
Right, correct. That would be great. I expected some of you to discuss the broken heart syndrome. I will not raise the name here. So I expected some of you.
I was about to bob up when you said that, but I
calm.
I could fight.
أنا ما مرتاحة صراحة للكالمنس بتاعته، بس يعني anyway let's just wait.
بلاش تقلب المواجهة.
خلاص ايوه خلاص سكت معلش. أنا هسي يعني سبحان الله حد جاب سيرتك يعني بس خلاص. ها more points to discuss. Okay. دكتور محمد, what do you think? محمد أنور.
هلا دكتورة.
أنا هنا بقول لكم كل سنة وأنتم طيبين.
وأنت طيب.
بكرة بنصالح دعواتكم، بكرة يوم طيب إن شاء الله.
إن شاء الله إن شاء الله. هم خلاص ما في سؤال ثاني يا شباب؟
I don't know والله ما في حد.
يبدو كده إنه ما في سؤال يا دكتورة ساشا، وشكرا لك، ما قصرت يا دكتورة، وشكرا للحضور.
Very nice and very interesting يعني صراحة.
والله يعني حاجة جميلة، وغايته بس يعذرونا لو حصل أي انتربت في أثناء المحاضرة من الشكل التقني وكده، إنه جاء أول مرة يعني، وإنه
يديكم العافية ما قصرت.
ما تكرر.
شكرا كثير دكتورة شاهية، ربنا يعطيك الصحة والعافية، وربنا إن شاء الله يتقبل من الناس الصايمين بكرة عرفة، وكل عام وأنتم بخير، وعيد سعيد عليكم جميعا إن شاء الله يا رب.
جميعا إن شاء الله يا رب. جميعا إن شاء الله.
شكرا لكم، شكرا لكل الحضور. شكرا دكتورة ساشا، شكرا من وقتك. شكرا. المحاضرة طبعا يا شباب حتكون مسجلة إن شاء الله، ومتى ما إنه يعني نشوف دكتورة سحر متى ما ترسل لنا او ترفعها بنرسل لكم الروابط، او ممكن نرسل لكم الفيديو ذات نفسه. انا ما اعرف كيف الطريقه، بس دكتورة سحر هي تكون عارفه الموضوع ده وماسكه وقاعد تسجل المحاضره يعني.
تمام. لو بعثت لي الايميل بتاعها ابعت لها السلايدز كمان يا دكتور.
خلاص تمام زين.
إن شاء الله.
اوكي دكتورة سحر، واصلة معك.
مع السلامة.
مع السلامة. مع السلامة. سلام. شكرا شباب. لو في اي واحد داري يقترح لنا كده انه هو حيشجع برضه، يعني يعمل لنا محاضرة من الشباب الموجودين كده، او بيقترح المحاضرات كده بالزوم ممتازة، ولا نمشي لللايف بتاع الفيس؟
لا لا محمد معك مهند أزهري.
هلا
بصراحة
مهند عارف.
بصراحة يعني المحاضرة اليوم
دارين
كانت
كومنتس. ايوه
جميلة
حلو.
كويس،
حلو.
والكونكشن يعني كان ممتاز جدا، والصوت
حلو.
كان كلير، وكل التكنيكاليتي في قاعدة الميتنج
حلو.
كانت ممتازة جدا.
يلا
هي بس احنا يعني محتاجين الفترة الجاية كده يعني، والحاجة برضه الكويسة شديد انها كانت بريف، يعني كانت يعني 1 اور، ما كانت حاجة طويلة شديد
الحمد
يعني الناس
لله.
لحد ما تزهق منها، ولا حاجة يعني كونسايز وشورت غير مفيدة، فكانت حاجة يعني في وقت كويس الناس استفادت منها.